So RAS mutations are common in acute myeloid leukemia. They are considered signaling mutations because they're activating of the RAS-RAF-MAP kinase pathway. They happen in about 15 to 20% of patients newly diagnosed AML, but are particularly seen in high rates, about 30 to 40% in patients with core binding factor leukemia, particularly in version 16. So we know it's something that promotes proliferation, and we consider it an activated signaling kinase mutation. We also know more recently with the use of targeted drugs such as IDH1 and 2 inhibitors, BCL2 inhibitors such as venetoclax, as well as even FLT3 inhibitors, that one of the mechanisms of resistance when you inhibit a certain pathway, one of the ones I described, is the development of other signaling mutations, primarily being RAS-RAF-MAP kinase, whether it be mutations in NRAS, KRAS, PTPN11, NF1, or even c-KIT. So these are, or CBL, and so these mutations tend to provide that proliferative growth advantage that is not adequately targeted by IDH1, 2 inhibitors, FLT3 inhibitors, or even venetoclax. And so we wanted to go back at our own population and describe the implications of RAS mutations in patients with newly diagnosed AML to understand how they responded with certain types of chemotherapy, whether one type of chemotherapy showed advantage over another. So again, we saw that RAS mutations were present in about 15 to 20% of newly diagnosed AML. They tended to be younger. They tended to be patients who had higher white count. They tended to be patients who had better karyotype, so either diploid or favorable karyotype. And if you look at just RAS mutations alone, they seem to predict for better overall survival. However, if you do a multivariate analysis, we quickly realize that the reason is that they segregated better with younger age, diploid karyotype, and favorable karyotype. So then we started looking at the types of therapy, and what we found is that indeed, as has been shown before, high intensity therapy using cytarabine or even high dose cytarabine was favorable in these patients, leading to higher rates of response and better long-term overall survival. When we then looked at, in comparison to hypomethylating agent, there was a clear trend towards improvement with outcomes, both CR rate and overall survival, when using cytarabine-based approaches rather than hypomethylating agents. So then the question is, well, in older patients, or patients who are unfit for intensive chemotherapy where you can't deliver high-dose cytarabine, what do you do when all you have is hypomethylating agents? So we went back and looked then at patients who are receiving HMA plus venetoclax, as well as a regimen of cladribine and low-dose cytarabine with venetoclax, which is another low-intensity non-anthracycline-based regimen. And what we found indeed in those patients as well is that venetoclax did improve response rates in those, but the best outcomes, both by response rate and overall survival, were among those patients who received this low-dose cytarabine plus cladribine-based regimen in combination with venetoclax. So overall, our conclusion was that hypomethylating agents, particularly as single agents, may not be the best option for those who have RAS mutations, but that you may want to consider cytarabine-based chemotherapy approaches, even low intensity, for patients who have RAS mutations baseline. There may be a suggestion that these cytarabine-based chemotherapy may start suppressing some of these RAS clones and hopefully in the future prevent resistance or outgrowth of resistant clones, which we're looking into right now.